Hi everyone, my name is Debbie Long and I'm from Brisbane, Australia. And today I'm going to be talking to you about long-term outcomes for critically ill children. I have no conflicts of interest to declare. So over the last few decades, we have seen a significant reduction in mortality in the paediatric intensive care unit. And so in some areas, we see this reduction down to 2%. And as a result, as we're seeing an increase in survival, we're seeing an increased number of children with new morbidities. And so we're experiencing a shift or a paradigm shift in survival to survivorship and understanding the impact of critical illness on a child long term. And, you know, I often get asked the question, is this a new problem? Well, in fact, no, I think it's been a problem that's been there all along. It's just that we have not been able to assess it or not have focused on it. So we've been focusing in the last few decades on rapid recognition and resuscitation, on obviously improving survival with that rapid recognition and resuscitation. And also we haven't had to hand the assessment tools that will measure the things that we want to measure down in the ages that we want to measure to. So in 2012, you may be aware that Dale Needham and his group developed the post-intensive care syndrome framework, and that identified 3 key domains: mental health, cognitive function, and physical outcomes. And they also recognise that family often experience impairments in mental health. So in 2018, Joseph Manning and team colleagues developed and identified post-intensive care syndrome in paediatrics. And as you can see in this image here, which has been adapted by Manning and et al.'s framework, the child is at the centre of this, and it's a dynamic process, and you can imagine that the child represents infants up until adolescence, so it's quite a heterogeneous sample. It acknowledges the 3 domains that Dale Needham acknowledged, and plus an additional domain, and I'll talk about that in a second, and also acknowledges that the critical illness in childhood occurs at a time of significant growth and maturation. It takes into consideration that often and increasingly now, children come into the critical care unit with baseline developmental impairments and also other chronic illnesses. The other thing about this framework is that it acknowledges the dependency between the child and the family or the parents. And so we often need to bear in mind that a child can influence a parent and their outcomes, and then subsequently a parent's outcomes can influence a child's outcome in return. In terms of the domains of developmental impact, we acknowledge that they are interrelated. And the one thing that I wanted to point out is the social health domain. So this was not identified in the adult PICS framework, but has been introduced into the pediatric PICS framework because of the importance of reintegration with peers, the importance of child and family social capital, and, for example, on the economic impact of unemployment. So, and then in addition, this framework has been adapted by Erica Fink and myself to include just acknowledging what the lifetime impact of critical illness is on childhood. And that is around learning, employment or work, relationships, family, and also long-term health. And the other areas that we can learn from is around neuroscience and the child development literature, in addition to the adult intensive care units that are already ahead of us, and some of our specialty area colleagues, such as the neonatal intensive care and congenital heart disease. Now, it's important to understand what is our current understanding of the impact of post-intensive care syndrome pediatrics. And as a rule of thumb, the understanding is that approximately the new morbidity rate is approximately 30% in children. However, as you can see by this slide, it may vary depending on the area that you measure or the domain that you measure, the severity of that impairment, the tools that are used for that assessment, and also the time frame in which children are followed up. And you can see on this slide here, I've got the 4 core PICS-P domains on the left-hand side and some other related outcomes on the right-hand side. And we can see worse IQ, visual motor integration, motor coordination, memory, behaviour, academic performance are all impacted by critical illness. We often see up to 60% of children experiencing physical impairments post-intensive care. And up until now, a lot of the focus has been around those physical impairments or really obvious impairments like blindness, deafness, cerebral palsy. But as we learn to understand more about post-intensive care syndrome in children, we need to take into consideration the whole child, including cognitive, emotional, and social. In terms of in the emotional domain, up to 60% of children can have elevated post-traumatic stress symptoms and then a full diagnosis in almost a third of children, and depression in 12%. Social domain, we don't have a full understanding on, but what we know already is that children are missing school, parents are missing work. It does impact on their academic performance. In terms of functional outcomes, this is a more broad term that we use, and we can see up to 60–70% of children will have some form of functional impairment after PICU, and in this case, sometimes up to 12 months. Health-related quality of life as a result of all these domains that are impacted is significantly reduced in children and in the families. In terms of parents, we know that the intensive care experience of their child affects them also. And so we have acute stress disorders, post-traumatic stress symptoms and diagnosis, anxiety and depression, all prevalent within this population. So as I mentioned before, there's a bit that we can learn from neuroscience and early childhood development literature. And so we know that the science of early brain development can inform investments in childhood. These basic concepts, established over decades of neuroscience and behavioural research, can help illustrate while child development, particularly from birth to 5 years, is a foundation for a prosperous and sustainable society. And that includes the care that we provide in PICU and beyond, particularly when we know that a significant percentage of the children who have a critical illness are under 5 years of age. So let's just think about some of these implications. The basic principles of neuroscience indicate that early preventative interventions will be more efficient and produce more favourable outcomes than remedial interventions later in life. A balanced approach to emotional, social, and cognitive and language development will best prepare all children for success in school and later in the workplace and community. Now, you might think, well, how does that apply to PICU? We know that we can encourage all these sorts of behaviours and developments even whilst they're in the PICU. For example, reading, playing with the child, talking with the child, and using our serve and return techniques. We also know that supportive relationships and positive learning experiences, although they begin at home, they can also be provided through a range of services, including the intensive care unit, with proven effectiveness. So babies' brains require stable, caring, interactive relationships with adults. Any way or any place that they can be provided will always benefit healthy brain development. So again, as a nurse or a doctor or allied healthcare professional caring for a child in the PICU at the bedside, we can be one of those healthy, stable, and positive relationships providing positive learning experiences. Science clearly demonstrates that in situations where elevated stress or toxic stress is likely, intervening as early as possible is critical to achieving the best outcomes. Now, some might argue that the PICU environment or our interventions are toxic or not toxic. I think if we look at it from a point of view that these are significantly stressful events and we need to enable our children to cope with them as best as possible. So for children experiencing these stressful experiences, specialised early interventions are needed to target the cause of the stress or protect the child from its consequences. So we're going to talk about a thing called PICU liberation in a moment, which might be helpful in either minimising or preventing some of these stress reactions. So what are some 8 top tips, things to remember about child development? Because I know as intensivists, intensive care nurses, allied health professionals, we're very much trained to narrow our focus in the lane of critical illness. But I want to encourage you to think more holistic about the child and yes, focus on rapid recognition and resuscitation, but also once that immediate crisis, critical illness period has passed, start thinking about how you can manage and treat the whole child. So my top 8 things to remember are: even infants and young children are affected adversely when significant stresses threaten their family and caregiving environments. So adverse early childhood experiences can lead to physical and chemical disruptions in the brain that last a lifetime. And the biological changes associated with these experiences can affect multiple organ systems and increase the risk not only for impairments in future learning capacity and behaviour, but also for poor physical and mental health outcomes. We know that development is a highly interactive process and life outcomes are not determined solely by genes. So that nature versus nurture debate is still out there. And while genetic factors exert potent influences on human development, environmental factors have the ability to alter family inheritance. So I'd like you to think about the environment in which your critically ill child is in, be it a paediatric intensive care unit or an adult intensive care unit, and how can you modify that environment to make it less stressful. While attachments to their parents are primary, young children can also benefit significantly from relationships with other significant and responsive caregivers, both within and outside of the family. So think about other kin for that child that can provide responsive caregiving, or if those are absent, are there staff and healthcare professionals who can provide that role? Because close relationships with other nurturing and reliably available adults don't actually interfere with the strength of a young child's primary relationship with his or her parents. And in fact, multiple caregivers can promote young children's social and emotional development. So the more that we can add to that, the more that we can build the architecture of a healthy brain and protect it while they're in ICU. And this brain architecture I'm talking about is all the neuron connections, and a great deal of that is shaped during the first 3 years after birth. But that window of opportunity for its development does not close on the child's 3rd birthday. So we don't just apply these principles to children under 3, but they continue to develop well into adolescence and early childhood. So although the basic principle that earlier is better than later, although that generally applies, the window of opportunity for most domains of development remain open far beyond the age of 3, and we remain capable of learning new ways to work around things or earlier impacts and to become more resilient well into the adult years. We know that severe neglect appears to be at least as great a threat to health and development as physical abuse, possibly even greater. So these are the children that we really need to look out for that come in with a critical illness or injury. And we know that young children who experience prolonged periods of neglect exhibit more serious cognitive impairments, attention problems, language deficits, academic difficulties, withdrawn behaviour, and problems with peer interactions as they get older. And this suggests that sustained disruption of what I mentioned before of the serve and return interactions in early relationships may be more damaging to the developing architecture of their brain than physical trauma, yet it often receives less attention. So if you have a child that comes in and you find that the parents or kin are not present, or they're physically present but not emotionally present, we know that in providing a stable, reliable adult in the form of a healthcare worker that can interact and engage with the child and using the serve and return, so that is talking to the child, waiting for a response, using the cues and conversations backwards and forwards, that is really important. And particularly acknowledging that even if a child with neglect is not the reason for their admission, but you suspect that to be something that's underlying. We know that young children who have been exposed to adversity do not invariably develop stress-related disorders or grow up to be violent adults. Although children who have had these experiences clearly are at greater risk of adverse impacts on brain development and later problems with, for example, aggression, they are not necessarily doomed to poor outcomes. And indeed, they can be helped substantially, again, if those reliable and nurturing relationships with supportive caregivers and healthcare caregivers are established as soon as possible and appropriate treatments are provided as needed. Just a few other things. Simply removing a child from a dangerous environment will not automatically reverse the negative impacts of that particular experience. So again, just removing a child from intensive care or resolving the critical illness does not necessarily negate the impact of that. And there's no doubt that children in harm's way should be removed from dangerous situations immediately. But that said, children who have been traumatised need to be in an environment that restores their sense of safety, control, and predictability, and that they typically require therapeutic supportive care to facilitate their recovery. So again, thinking back to our critical care environments, what can we do within their care, within the environment that supports their sense of safety, their sense of control, and their sense of predictability? So having parents present a lot of the time, giving them forewarning, asking them to be involved in the cares, asking children, involving the children, and letting them have a sense of control over the order of things or the intensity of things, and also the predictability, having a plan of care based on how their day-to-day functioning is at home and what they do, and so that they can predict what's going to happen next. And obviously, as children, that's different and varies according to their age. Just coming to these last few points here, resilience again requires relationships, and it's not about rugged individualism. And our personal capacity to adapt and thrive despite adversity develops through the interaction of, again, these supportive relationships, biological systems, and also our gene expression. And despite the widespread yet wrong belief that people need only draw on some heroic strength of character to get through a stressful experience, science now tells us that it is the reliable presence of at least one supportive relationship and multiple opportunities for developing effective coping skills that are the essential building blocks for strengthening the capacity to do well in the face of significant adversity. So again, I can't overemphasize just having a stable, present, caring healthcare worker around a child and their family speaks volumes. So just going back to PICU now, we've talked about child development literature and neuroscience. And moving back to post-intensive care syndrome, there's actually a growing list of risk factors to help explain the development of PICS-P. But some of these factors that we know about are not actually modifiable. And it's important to our understanding is where and when we can intervene to either prevent or minimize some of these risk factors. So you'll see over here in the red box, these are some of the risk factors, and we'll come and talk about these again. And then in terms of intervening, we actually have two opportunities. One is within the ICU and one is outside of the ICU. So both of these strategies have been developed by the Society of Critical Care Medicine and are worthy of mention. Thrive is the implementation of that post-intensive care follow-up, which is through various means, including clinics and peer mentor support groups. But this, as I mentioned before, occurs after the intensive care admission. So what can we do as clinicians within the intensive care environment that is integral to the care of the child that could ameliorate the impact of critical illness? And that's where liberation, or the A to F bundle, as the second concept introduced by the Society of Critical Care Medicine, comes into play. And it consists of the implementation of this bundle here, or a version of it. And these evidence-based principles were introduced to reduce harm and improve recovery. And essentially it was created in a way to operationalize the guidelines that we have that already exist that people were finding difficult to translate into practice. And we know that the efficacy as well as the dose response effect has already been reported to impact several meaningful patient-centered outcomes in adults, including mechanical ventilation times, delirium, length of stay, and survival. Liberation is the second concept introduced by the Society of Critical Care Medicine and consists of the implementation of this A to F bundle. And these evidence-based principles were introduced to reduce harm and improve recovery, and in a sense were developed to try and operationalize some of the guidelines that we have, particularly in adult intensive care, that have evidence to demonstrate improved outcomes that we were having difficulties putting into clinical practice. And the efficacy of these bundles, as well as a dose response effect, has already been reported to impact several meaningful patient-centered outcomes in adults, including mechanical ventilation times, delirium, length of stay, and survival. And by dose response, I mean that even implementing the smallest amount of liberation will have a positive effect, but obviously the more that you can implement, the bigger the response or the effect is going to be. So let's just have a look at some of these risk factors. Now, before I mentioned that some risk factors were modifiable and some were not modifiable. And so if we have a look at the three areas of risk factors, we'll see that child factors are not really modifiable, nor are parent, family, or environmental risk factors. We can't really modify those, but we can look at the illness and the treatment factors themselves to see where we could minimize or prevent harm. And so this is really the factors that the A to F bundle or the PICU or ICU liberation really hones in on. So things like mechanical ventilation, the length of mechanical ventilation, whether it's related to sedation and opiates or not, significantly increases the risk of poorer long-term outcomes. And obviously there's a correlation again with PICU length of stay in that. Vasoactive medications, ECMO, CVVH and renal replacement therapies, and even just invasive procedures increases a child's risk for psychosocial impairments. We know benzodiazepines and opiates can impact on long-term outcomes in addition to delirium. And while I say that the child factors and the parent factors or environmental factors are non-modifiable, it doesn't mean that we can't do anything about those. It just means that we need to be mindful of them as the child comes into intensive care, that we understand that they might be more at risk if they are a child with more internalizing behavior, so shy, withdrawn. If we know that they have a premorbid neurodevelopmental disorder or neurodevelopmental impairment, if they have other chronic comorbidities, then first and foremost, we should be thinking that they will be at risk even before we start providing treatments. Similarly, with parent, family, and environmental factors, how can we support parents in terms of providing education material? If they have a history of mental illness or even distress, how can we support our families to build coping, resilience, and self-efficacy within the PICU and also post-PICU in order to optimize their child's recovery? So that even though these factors are non-modifiable, we can still bear them in mind and consider how we provide care to optimize that recovery. So let's take a look at the steps to liberation. So I said there was an A to F bundle, but you'll notice in this that there's also G and H, and there's baby liberation down the side. And that is how we have translated and adapted it for our pediatric intensive care unit. But it's a forever evolving thing. So it started out as ABCD and then has gotten bigger and bigger. So why is it called liberation? This was the term that SCCM labelled it, but it's to help liberate a person, every patient, every day, to liberate or remove them from the intensive care, to remove them from the procedures and the sedation. And I really want you to think about this as not just another list of assessments that we should be doing or documenting, and not another fad which will pass in another few years. These are fundamental principles of basic healthcare that we should be providing to all of our patients. And even though it might look like this only applies to ventilated patients, it doesn't. It applies to every child, every day. And we want to get children back to being children like they are at home. And I don't know if you've noticed, but if you look at the elements of this PICU liberation, they actually align with some of the neuroscience of developing and protecting brains, and the principles also of trauma-informed care. And particularly, as I mentioned before, most of our children are under 5 years of age, and that brain architecture developing period should be protected. So we can start by trying to implement some of these strategies within the PICU or the adult ICU, even for children in an adult ICU, to help optimize their recovery in the ICU and after the ICU. Now, I mentioned that liberation came about by trying to operationalize some guidelines that the adult ICU had in order to improve care. And interestingly, for quite some time, even though we use liberation in pediatric ICUs, we didn't have a corresponding pediatric guideline that matched with liberation. But I can say now that as of earlier this year, Heidi Smith and a lot of other well-known pediatric intensive care colleagues have developed the Pediatric Pain, Agitation, Neuromuscular Blockade, and Delirium and Critically Ill Pediatric Patients Guidelines, or the PANDEM guidelines. And that's with consideration of the PICU environment and early mobility. And they issued in this document 44 recommendations. 14 of those were strong and 30 of them were conditional. And within that, they had 5 good practice statements. And the main areas focused on the need for routine monitoring of pain, agitation, withdrawal, and delirium using validated assessment tools, enhanced use of protocolized sedation and analgesia, and lastly, the recognition of the importance of non-pharmacological interventions for enhancing patient comfort and comprehensive care provision. If we have a look at there's a summary in a schematic summary of the recommendations from these Pandem guidelines. And I would recommend you printing off these and having them around your intensive care unit, or even making them into smaller lanyard cards if that's something that you can do. So there's two sections to it, A and B. So this is A, and it's broken up into pain, sedation and delirium across the top, and down the side, assessment, risk factors, complications and management. And I recommend these as a great go-to guide to help you work through the care of children in your intensive care unit. And then similarly, on the flip side to this, there's neuromuscular blockade, withdrawal syndrome, and also the PICU environment and mobility. So each of these areas really link in with the liberation areas. So let's look at the liberation areas in more detail. So I've broken these up into the bundle areas A, B, C, D on this slide, and then the next four on the subsequent slide. And we know that several studies have identified illness and PICU treatment factors that have been associated with poorer long-term outcomes in children. And as I mentioned, a particular note, treatment risk factors are often seen as the most modifiable. So therefore, interventions in those areas will potentially have the most impact. We know from the child development literature that pain influences temperament and self-regulation and attention, and when sustained, they can have lasting impacts. We know from the NICU and the pediatric ICU literature that opiates can impact long-term outcomes, and also the use of methadone. In terms of B, the breathing space, we know that light sedation is better than deep sedation, and if we can achieve light sedation, that might help us to reduce the length of mechanical ventilation. C is quite a big space, and it's around the choice of sedatives. We know that benzodiazepines have an effect on delirium, and that delirium can have an effect on post-traumatic stress. We know that midazolam also impacts post-traumatic stress and cognition particularly in adults. And that nurse-driven protocols or protocolized sedation and analgesia guidelines are seen to be quite efficient and effective. Going back to delirium, we know that there's a relationship between delirium and cognitive decline, but also in quality of life. So anything that we can do to minimize the impact or prevent delirium would be optimal. Moving on, sorry, I'll go back. Moving on to E, F, G, and H. E is another big space related to the neuroscience and early childhood development literature, because we know that movement and play and socio-cognitive development are huge. And we can do those things in ICU with a child. Just because they're unwell does not mean that they can move, and does not mean that they can play. And that movement and play will stimulate that socio-cognitive development. And it will also help to decrease delirium. F is about family engagement and empowerment. And we know that in family engagement, in decision-making and cares, and also the presence of family, particularly in the NICU environment, will improve neonatal outcomes and also child outcomes. G is something that we've added, and H in our intensive care unit is for good nutrition and humanism. And we know that from the child development literature that adequate nutrition equals good development, physical development and brain development. And out of the PICU literature, we know that tight glycemic control and withholding parental nutrition in that first week of intensive care admission will improve outcomes, particularly related to executive functioning and even out to 4 years of age. Humanism is really promoting family-centered care and child-centered care, and we can see satisfaction and decrease anxiety and distress in parents where they're included in family-centered rounds, involved in developing daily routines and providing soothing cares for children. And we can involve them in things like reading and play and activities, and encouraging them to participate in these activities where we reinforce and engage those serve and return principles. And if they can't be deployed or implemented by parents or other kin, then we can be a surrogate and do that. So just lastly on liberation, we included baby liberation because we wanted to acknowledge the importance of neurodevelopmental cares. Now, while we focus specifically on children under the age of 6 months in our unit, we know that neurodevelopmental cares are important for children of all ages. So if it's important, or if it's a part of everyday life that's important to your child in your home, then it's also important to try and implement those within the PICU. And I always use the example of the fact that my 12-year-old son still likes cuddles with mum at night before he goes to bed. And so if we can integrate those into the PICU care routine, then that would be really important for my child and for my distress within the PICU. But we know from the neonatal literature, the FINE programs and the NIDCAP programs, that some of these developmental cares can have an impact on neonatal cognition, mental recovery, psychomotor performance, and language development. So it's really important if we can try and implement these where possible, and even swaddling and nesting. And at the very least, if some of these areas have not shown to have improvements, they certainly don't have a negative impact on the child and the family, and certainly help at least with things like bonding. So coming to an end now, what are the implications of all of this for clinical practice? What can we take from neuroscience and child development literature and the information that we understand about minimising harm in the PICU from a liberation perspective? How can we bring that into our day-to-day practice? And I would argue, whether we're in high-resourced areas or low-resourced areas, a lot of these cares are not based on material items. It's about interaction and availability of stable human beings. So from a child development and neuroscience lens, we need to optimize those principles. So where we can, decrease any stresses for both the child and the parent, and remember that connection and partnership between the child and the family. Try and have as many supportive relationships around the child and the family as possible. And that includes both kin or other family members or staff. And it doesn't matter, the more the better. And part of this includes opening up our access into the intensive care unit. We really should not be restricting our access for caregivers unless we have a good reason around pandemic responses, etc. Trying to provide, even within the intensive care unit, as many positive experiences and developmental cares and cues as possible. So this includes reading and playing. And like I said, it's our job to try and get this child as back to being a child as possible and as normal, even if they're in the intensive care unit. And please remember that even babies and children cry in ICU for reasons other than pain or discomfort. So normal babies at home cry, and we don't immediately assume pain. We think about hunger, we think about nappies, we think about comfort. So please remember those as well, and that we don't treat crying with sedatives or opiates. In terms of optimizing the PICU liberation principles, we want to treat pain when they have pain, but importantly, and if the only thing you do is to assess for pain, agitation, delirium and withdrawal and do something about them, that would be a wonderful start. We want to, where we can, minimize the use of benzodiazepines. We want to encourage the use of movement and mobility. Now, this is not having every ventilated child with an ETT walking down the corridor. This is about having an infant out on a playmat playing with a Playmobil. It might be having a teenager sitting out of bed in a chair playing on a Nintendo. So bringing in their normal movement and mobility routines from home into the ICU. Really consider and encourage family engagement and empowerment, and including them in the decision-making and the partnership in the care. And this lends to the humanism and considering the whole child and the whole family and that partnership in the care that you provide. And I really want to ask you to look beyond a single child as a disease or an organ or as a body, and consider all of those domains of post-intensive care syndrome and all of those domains of healthy child brain development. And lastly, really embrace the non-pharmacological comfort measures. At home, if we had a distressed child, we wouldn't normally just assume that a medication would solve something. So if they are crying or upset or uncomfortable, what are some of the non-pharmacological measures that we can use to provide comfort and care for the child? And that includes support from the families. I want to thank you for inviting me to present this talk, and I can really recommend a few resources for you, in particular the Centre for the Developing Child in Harvard, and the Society of Critical Care Medicine has wonderful resources around liberation. And also we have a website, which is Piccolo, Pediatric Intensive Care Optimising Long-Term Outcomes, which we're building a repository of resources in, not to mention several other websites which will also have that material available. Thank you very much.